All right, our lecture today is on multiple sclerosis and neuromyelitis optica. Trying out a new microphone today, so hopefully the sound quality will improve a little bit. So I want to just back up first and describe big categories here. We have two categories of CNS diseases that affect white matter, demyelinating and dysmyelinating. Our lecture today will be entirely on two demyelinating conditions, multiple sclerosis and neuromyelitis optica. And when we use that term, we mean that the myelin was initially formed normally and then something happened and there's some damage. In contrast with dysmyelinating diseases, and there the myelin was never formed properly. And so Dr. Deich will go over the leukodystrophies with you. The topic of multiple sclerosis is such a big one, and with all of the new medications that are out, we're just going to stick with demyelinating diseases in this lecture. So as a very kind of bird's eye view here, we want to remember multiple sclerosis as a condition that affects central nervous system myelin, which remember is all of the myelinated pathways in the brain, brainstem, cerebellum, spinal cord. Those are all myelinated by oligodendrocytes. And importantly, don't forget that the optic nerve is a central nervous system pathway. And so myelinated by oligodendrocytes. And so we'll see that's one of the most common manifestations of multiple sclerosis is visual loss. So there are several things that come together that put someone at risk for developing multiple sclerosis. More is known now about genetic factors, so that there's something there. There are probably environmental factors, although those have really not that well been sorted out. We'll talk about vitamin D and smoking and some other things that are related. And then there is obviously dysfunction of the immune system. So let's talk a little bit about that. So as I said, there is a defective immune response. We know that early on patients with multiple sclerosis have disruption of the blood-brain barrier. We can see that when we do an MRI scan with gadolinium, so things will light up. And so simplistically, if we have somewhat of a leaky blood-brain barrier, we may have components of the immune system that gain access to the central nervous system where they don't belong and can damage oligodendrocytes. So there are autoreactive lymphocytes and monocytes that through adhesion to endothelial cells gain access to the central nervous system, again with that somewhat leaky blood-brain barrier. There isn't a definitive target. There are some interesting things in recent years that have come out about some antigens that may be the target, so I'm sure more will be known about that. But right now we don't have a definitive target, and therefore an easy blood test like an antibody test or something like that we can do to make the diagnosis. In terms of environmental factors, this is just very interesting. The idea here is that basically the further away you are from the equator when you grew up, the higher your risk of getting multiple sclerosis is. And we can see that just in a map of the United States. So you can see if you grew up in Washington or Minnesota, some of these northern states, Vermont, your risk is higher than if you grew up in Southern California, Texas, and Florida. And if we look at a map of worldwide distribution of MS, again, we see the same thing. So Northern Europe, relatively higher incidence. Canada, higher. And even when we go down here to Australia, we can see that the further away from the equator you move, down here to New Zealand, the higher the risk of developing multiple sclerosis is. So there are some ideas about why that is, but we just know that basically where you grew up between the ages of 5 and 15, those seem to be the years that determine your risk of getting multiple sclerosis. Or I should say that's one determining factor. There's been a lot of discussion and some interesting things about possibly viral infections being related in the pathogenesis. That's still not entirely clear. There's no relationship to vaccines, so that will often come up in conversation with patients. In the last probably 8 to 10 years, there's been a lot discussed about vitamin D and its relationship with multiple sclerosis. So we do know that women who have a high milk intake, vitamin D intake during pregnancy, that their children have overall a lower risk of developing multiple sclerosis. And likewise, there's a higher incidence of MS with births in the spring. And so basically, babies that are carried through the summer have a lower risk. All right, so births in the spring, less sun exposure overall during that 9-month period of time, therefore a higher risk of multiple sclerosis. So all of that is fascinating, but to date, there isn't any evidence that suggests giving vitamin D supplementation is helpful for patients that have multiple sclerosis, yet clearly there is some relationship there. Within the last couple of years, smoking has been identified as a risk factor for developing multiple sclerosis. All right, so we have immune dysfunction, we have environmental factors, and now genetic factors. This is very complex. HLA-DRB1 is the most important risk locus for multiple sclerosis, and interestingly, that overlaps with vitamin D, so there may be a tie-in there between genetic susceptibility and vitamin D or vitamin D deficiency. And there have been many different locations that have been identified. Overall, if we have a sibling that has multiple sclerosis, the other sibling has a risk of MS of about 3 to 5%. So it's a somewhat increased risk. So let's move on to the clinical features. As we've emphasized quite a bit, younger individuals get multiple sclerosis. So on average, the peak is around 30, late 20s, but you can see the range there is between ages of 15 and 45. So if someone is having symptoms, let's say that comes on in their late 50s or 60s, or even just after 45, really MS should not rise to the top in the differential diagnosis. So when I think of this as mainly an onset in younger individuals, it's more common in women by a 2 to 3 to 1 margin. There is a less common form of multiple sclerosis we'll talk about called primary progressive multiple sclerosis, and men are more likely to get that form. So MS presents with episodes that come and go. There are distinct attacks on the myelin, and so we refer to these as relapses. And so one of the most common involves the optic nerve. And so if you have an optic nerve demyelination, this is called optic neuritis. And this presents usually with a loss of central vision. So therefore, visual acuity is going to be quite diminished in that eye. These come on fairly abruptly over hours, so patients often will come into the emergency room with visual loss in one eye. Because there's some inflammation in this process, there's often pain behind the eye. Patients will describe looking around that they have pain in the eye. Loss of color vision is also really common during the attack of optic neuritis. And so these can be quite severe during the attack. And if we do an MRI scan with gadolinium, here's a normal optic nerve over here, we can see objective evidence of this optic nerve just kind of lighting up over here. So, how can we objectively, if someone just says they can't see in one eye, how can you objectify that? Because really, when you look in the eye of someone that has optic neuritis with an ophthalmoscope, let's say you're seeing someone in the emergency room, it looks normal. Okay, so the rule of thumb with optic neuritis acutely is the patient sees nothing and you see nothing. You see nothing abnormal. All right, so how can we objectively make this determination? And so here's a nice drawing that a medical student did for me a few years ago. And so let's just first consider the normal anatomy. Remember when light here comes in through the optic nerve that some is going to cross on the chiasm, some will stay on the same side, and that with regards to the pupils, this goes back to the pretectal nucleus, where there's crossing over here. Maybe you want to label right here, this is the posterior commissure. Okay, and then the Edinger-Westphal nuclei are stimulated, and then the output goes to the ciliary ganglion here to constrict both pupils. So just notice that the light in one eye, it actually crosses twice. It crosses at the chiasm, it crosses at the posterior commissure, so that light in one eye will equally stimulate both Edinger-Westphal nuclei, and both pupils will constrict symmetrically. All right, so now let's say we have a patient that has optic neuritis here in the left eye. And so they have visual loss in the left eye, but notice when you look at that patient, the pupils are symmetrical. Okay, why are they symmetrical? Well, the light getting in the normal right eye is going to equally stimulate both Edinger-Westphal nuclei, and the, let's say just 10% of the light is getting in this eye. Well, that 10% is still going to equally stimulate both Edinger-Westphal nuclei. So therefore, the parasympathetic output to the pupils is equal. All right, and so the pupils are symmetrical. Okay, so we have symmetrical pupils with any optic nerve lesion. Now, let's say we shine the light here in the left eye, and depending on how much light gets in, if it's only 10%, they won't constrict too much, but here you can see both pupils get a little smaller. When we shine the light in the normal right eye, okay, now much more light is getting in, and so you can see that the pupils constrict more briskly. Now, in the real world, this, may seem like, oh, this should be obvious, but it really isn't that obvious. And so what really is helpful to bring this out is to do the swinging flashlight test, where we swing the flashlight back and forth from the normal to the abnormal eye. And so if we shine the light in the normal right eye, both pupils are going to constrict briskly. Okay? But what happens now is when you swing the flashlight back to the abnormal eye, both pupils are going to dilate. And both pupils dilate because you went from blasting away the Edinger-Westphal nuclei with lots of stimulation to cause pupillary constriction to now very little light stimulation of the Edinger-Westphal nuclei, and therefore both pupils dilate. Now you're looking here at the left eye when you do this, and so it's very strange when you see it. You swing the flashlight to the left eye, and the pupil is actually getting larger as the light is going into the left eye. Okay, so that is called the afferent pupillary defect. And you need to do this test on a lot of normal people before you can really kind of get good at detecting it in someone that has optic neuritis. All right, so I'm going to try showing you a video here. We'll see if this works, of a patient who has an afferent pupillary defect. Now, the camera goes out of focus here initially, but towards the end of the video, I think it shows up pretty well. Okay, so all right, so hopefully we're able to see that, but that is then going to be our objective test there for optic neuritis. So if someone says that their eye is blind and you don't, if you don't have an afferent pupillary defect, then we begin to wonder, is something else going on? Is this a genuine process or not? All right, so optic nerve is commonly affected. Upper motor neuron pathways are also commonly affected in multiple sclerosis, most commonly in the spinal cord. So transverse myelitis, which we mentioned in the spinal cord lecture, is a very abrupt condition. So patients are weak and have sensory loss below the level of the lesion. So usually paraplegia, okay, because the demyelination is in the thoracic cord. So the arms are usually normal unless we were to have an unusual, very high level of the lesion. And again, bowel and bladder function with any spinal cord lesion is expected. Okay, less commonly, if we were to involve like the corticospinal tract and the brain, a patient could have hemiplegia during an attack. Okay, what about demyelinating lesions in the brainstem? Well, the most classic pathway affected in the brainstem is the medial longitudinal fasciculus. So recall that a lesion there gives patients an INO, an internuclear ophthalmoplegia. So I won't go over the anatomy again because we did that quite a bit last year, but recall that the medial longitudinal fasciculus is important for how your eyes work together looking from side to side. So this patient has a right medial longitudinal fasciculus lesion. A left medial longitudinal fasciculus lesion. Because when she looks to the right, notice that the left eye is not cooperating here. And that is because of the left MLF lesion. So this eye does not look to the nose. Now, I should have a picture here showing you the patient looking to the left, and there it's normal, because the left eye abducts normally, the right eye is able to look to the nose. So the abnormality is always on the side of the eye that doesn't look to the nose adequately. And as we mentioned last year, the brain doesn't like to have double vision. And so it tries to bring the images together by bringing this normal eye back to the midline. And so we get some nystagmus here in the normal eye. So don't be confused by that. If you see nystagmus in just one eye, by far the most common cause would be an internuclear ophthalmoplegia. Now this is an older individual who actually had a stroke involving the MLF. But if you see an INO in a young person, it's multiple sclerosis. Okay, and this pathway is very midline. So oftentimes if we have a demyelinating lesion midline, we'll get bilateral MLF pathways, and then neither eye looks to the nose very well. It's called a bilateral INO. And both eyes tend to look out a little bit in that situation. So anything in the brainstem can be affected. There are complex vestibular pathways in the brainstem, and so those are myelinated. So patients may present with vertigo or have vertigo during an attack. If the corticobulbar tract is demyelinated, they may have dysarthria and dysphagia. These patients can have pseudobulbar palsy if you demyelinate a lot of the corticobulbar tract. And when we get into the stroke lecture, we will talk about the crossed findings with brainstem lesions. So I'm going to emphasize those crossed findings in the stroke lecture, but just concisely to say for now, that is the hallmark of a brainstem lesion: ipsilateral cranial nerve, contralateral motor, or sensory deficits. Now, a unique thing for multiple sclerosis is that the trigeminal nerve fibers can be affected once they enter the pons. And if we have demyelination there, it irritates trigeminal processing, and patients have these very sharp electrical sensations of pain, usually in the V2 distribution, like in the cheek. And so that's usually caused, or triggered, I should say, by any jaw movement, talking, chewing food, brushing teeth. And so if we have a younger individual presenting with electrical jaw pain, that's actually raises a concern about multiple sclerosis. Okay, sensory pathways can be affected. I mentioned the tight band around the waist with transverse myelitis. But if we have sensory pathways involved in the brain, then the patient may lose sensation on one side of the body. And remember the posterior columns, which are heavily myelinated, that if we have anything that affects the posterior columns, patients may have Lhermitte sign, that electrical jolting sensation that goes down the spine. That's not specific for any condition. It just tells you it's spinal cord and more specifically its posterior column. All right, cerebellar pathways are heavily myelinated. So these patients frequently have ataxia. Okay, they frequently have nystagmus because the cerebellum is involved in coordinating your eye movements. And the cerebellum doesn't just regulate your arms and legs and eyes, it even controls and regulates how you talk and swallow. And so these patients can often have kind of a, we call it an ataxic speech pattern. Now, so patients present with episodes, like they may have an episode of optic neuritis and then it gets better. And then a few months later, they may have an intranuclear ophthalmoplegia with double vision, it gets better. And then they may have transverse myelitis and it gets better. So that's the more typical form of multiple sclerosis. There's another form that's very different, and that it usually presents in middle-aged men, so maybe someone in their 40s, even early 50s, that is just a progressive gait ataxia. Every month it gets worse than the last. So it's not, so much the attacks, it's just a steadily progressive course. So again, that form is more common in men. Bowel and bladder function is, well, not so much bowel, but bladder dysfunction is very common. Sexual dysfunction is very common. These pathways are closely related to each other. And so that eventually develops in up to 90% of patients with multiple sclerosis. And behavioral changes are common in multiple sclerosis, in at least 70%. And a lot of this is not just patients feeling sad about their condition, but really this is an organic part of the condition. So depression is most common, but some patients may have a euphoria, which I've seen in a number of patients. They come in, they're worse, and their mood just doesn't, their affect just doesn't correspond to that. They seem elated in the context of clinical deterioration. Fatigue is very common in multiple sclerosis. And so when you have a patient complaining of fatigue, which of course a lot of people notice, in multiple sclerosis, the distinctive feature is often it's very heat related. So if they're out on a hot day, it just exhausts them. And often we'll have what's known as the UTOF phenomenon. And so the most interesting case I saw of this was a man who had optic neuritis. He had a pretty good recovery. His vision didn't get entirely back to normal, but he went to the beach one weekend and it was very hot. He laid out in the sun all day and he got up, and that same eye where he had optic neuritis in before, he lost the vision in that eye. It was a dramatic change. And so he thought he was having another attack, and he cooled down, took a cold shower, and a couple hours later the vision was back to normal. He came into the emergency room, but this is not a new attack of optic neuritis, but rather heat slows the conduction along myelinated pathways. And so overheating tends to bring out previous symptoms of demyelination. All right, so relapsing remitting is the most common form, and 85% of patients will have that form of multiple sclerosis. So again, that is a patient with optic neuritis, got back to normal. Intranuclear ophthalmoplegia, got back to normal. Transverse myelitis, and I'm just throwing these out randomly, but the point is the more episodes you have, the more likely then you don't get back to normal. Okay, just enough of the nervous system pathways are affected, and now with further attacks, patients just don't come back to baseline. So that's why we really want to very early on be aggressive in making the diagnosis, getting patients treated to try to prevent this kind of downward decline. Now, these numbers will improve as our treatments have improved dramatically in the last 10 years, certainly. But many patients that start out with a relapsing remitting multiple sclerosis will eventually merge into a secondary progressive form of multiple sclerosis, where it's not so much characterized by attacks, but more just gradually getting worse over time. Right? So that is secondary progressive MS. Primary progressive MS, again, these are the men that are a little older, 40s, 50s, makes up only 15% of cases, and these are patients that just steadily decline, mainly with their walking. It's a progressive gait ataxia. All right, so this is kind of a busy slide here, just showing you kind of a natural progression of multiple sclerosis. So we have an initial event, okay, optic neuritis, transverse myelitis, something like that, okay, and it can be difficult when someone has their first attack. You know, there's a differential. Maybe it's something else. But as patients begin to have more attacks, well, then there's no mystery, you know, in the diagnosis. And our testing here, even with the first attack, is now so good, we can often make the diagnosis here. But someone has clinically definite MS here, certainly when they're having more relapses. So again, we're trying to prevent the merging into the secondary progressive form with more disability. Okay? Now, we follow MRI scans in patients that have multiple sclerosis, and certainly the burden of white matter changes in the brain increases over time. Okay, and there's some different specific things there. Oftentimes when someone has had lots and lots of demyelinating lesions, then their likelihood of having some memory cognitive issues increases. And we do what is really not much we can do about this once this develops is when we have some loss of brain volume. Okay, our therapy can't undo those changes. So when we think about multiple sclerosis, our most helpful test is an MRI scan of the brain. Okay, even if someone has transverse myelitis, yeah, you would image the thoracic cord. But if you're also seeing demyelinating lesions in the brain, then that patient has multiple sclerosis. And the classic thing of these demyelinating lesions is that they tend to line up around the lateral ventricles, these periventricular lesions, okay, which we can kind of see over here as well. We use the term Dawson's fingers to describe kind of these fingers projecting almost into the lateral ventricles. I don't show this here, but often the corpus callosum, which is heavily myelinated, we can have demyelinating lesions there as well. And we can look at the spinal cord. We can see these little spots here of demyelinating lesions in the spinal cord as well. Okay, here's a horizontal section, little arrow showing you a small area of demyelination. Now, usually, if the clinical picture fits, the MRI fits, we have our diagnosis, multiple sclerosis. But occasionally patients may have an atypical story, complex findings that don't fit perfectly, and in those cases we'll do a lumbar puncture. Okay? So what we're looking for in the cerebral spinal fluid are oligoclonal bands, which reflects a change in the IgG synthesis rate. And so we're going to see oligoclonal bands in 80 to 85% of patients. So if we're kind of doubting multiple sclerosis, but it's still in the differential, we do our lumbar puncture, and it's normal, now we're even further pushed away from the diagnosis of multiple sclerosis. All right, another test that can sometimes be helpful is called a visual evoked response test, where we have the patient look at a computer monitor that has kind of a checkerboard pattern that changes, and we can monitor with an electrode back here in the occipital lobe how long it takes that vision to get back to the occipital lobe. And so because myelin is important for the speed of conduction, and we know how long it should normally take vision to get back to the occipital lobe, we have a prolonged visual evoked response in patients with a demyelinating disease, like multiple sclerosis. All right, so again, I think a lot of the data about prognosis is based on information prior to a lot of our newer effective therapies. But what we have usually said as a general rule is that a third of patients have limited deficits throughout their lifetime, a third have some disability but continue to function, and a third become disabled. I am, especially when you diagnose multiple sclerosis in a young woman, I am very optimistic, I think realistically so, that most likely you're going to do quite well with this. We have good therapies, and most patients respond to those therapies. Patients will often look on the internet and find, the worst case in a celebrity of multiple sclerosis, someone who is wheelchair bound and died of MS, and so people assume that that's what it's going to be like for them. But you can see most patients, at least 2/3 of patients, do very well. Yes, have some annoying symptoms and problems, but are functional. Overall life expectancy is 7 years less, but that seems to reflect the primary progressive form, which is almost like a different condition from the more typical relapsing remitting multiple sclerosis. So again, women that have relapsing remitting MS when they're younger at onset tend to do quite well. All right, so let's talk about treatment. So we want to distinguish acute treatment. So someone just has transverse myelitis or optic neuritis. What are we going to do for them in the hospital versus disease-modifying therapy? In other words, what we're going to do long-term to try to prevent relapses. So when someone comes in with a significant relapse, not just a minor sensory symptom, but really a significant issue, we give high-dose methylprednisolone. It's a high-dose steroid, and it appears to decrease capillary permeability, which will decrease the swelling a little bit, but it also reduces the leukocyte migration to the area of inflammation. So that appears to be the mechanism. And so this is often rewarding to do. You have a patient come in with transverse myelitis, they can't walk, give them high-dose steroids, and usually within a few days they're turning the corner and they're better. Now, once we've kind of treated the acute episode, we need to discuss, okay, how can we intervene now just so that the rest of your life is better and you're less likely to have more of these relapses. So the interferons came out, I think, in the mid-1990s, 96, 97, something like that, as the first treatment. And shortly after, GLATIRAMER acetate came out. And so these were the two categories that were used for more than 10 years for multiple sclerosis. So you can see there in the interferons, we have interferon beta 1b and 1a, and these are subcutaneous injections that differ in several properties, but they're all injectable forms that are given either once a week or every day. And the idea here with the interferons is that it probably reduces expression of this adhesion molecule on T cells. And so by reducing the expression of this, this seems to be important for perhaps T cells getting across the blood-brain barrier. So it kind of makes them stickier, think of it that way, and therefore less likely to gain access to the CNS through this leaky blood-brain barrier in someone with multiple sclerosis. Right. Side effects mainly relate to just having local pain where the injection was done. Some patients can have some flu-like symptoms and occasionally some liver dysfunction, so we may check liver tests occasionally. If a patient's doing very well on interferons and then they stop doing well, then you need to check for neutralizing antibodies, which form against the interferon. And if that happens, then the interferons lose their effectiveness and you need to move on to a different therapy. GLATIRAMER acetate, I won't ask you the mechanism here because it's very complicated and I think people aren't entirely clear on the mechanism, but this is a daily subcutaneous injection, usually very well tolerated, although some patients may have this very dramatic attack with flushing, chest pain, palpitations, sort of like we were talking about autonomic dysreflexia, very dramatic like that. Not life-threatening, but distressing. And so if they have that, then you'll want to move on to something else. It's a very safe treatment, which is nice. And so kind of an idea here, again, I won't ask you this, but glatiramere acetate here gets presented to an antigen presenting cell, and it probably has the effect of changing this naive T cell into a T helper cell here, which may act to suppress inflammation in the central nervous system. That's one theory, at least. All right, so these two medications, classes of medications in interferons, and there are 3 of them, and glatiramere acetate, we have a long track record. They're very safe. In general, they reduce relapses by about 30%. Now, a lot has changed in the last 8 years or so. Dimethyl fumarate came out as the first oral medication for multiple sclerosis. I believe it was the first one. This has an interesting story. This is a medication used to treat psoriasis, and it was found to be helpful for psoriasis because it's a toxin that was put on furniture. And as I heard the story, individuals with psoriasis who would sit on this furniture treated with dimethyl fumarate noticed an improvement in their psoriasis. Okay, so that's how it came out as a treatment for psoriasis. And then it was discovered that patients with psoriasis who had multiple sclerosis, who were on dimethyl fumarate, found that their multiple sclerosis was getting better. And so that's how we moved from a furniture toxin to an FDA-approved medication for multiple sclerosis. So again, it's an oral medication, and that's a good thing. It's more effective. Patients are very happy if they don't have to inject themselves. Usually people don't like that. And it's more effective than the interferons and glatiramere acetate. Side effects are not common. Flushing is the most common, so patients often when they take the medication may experience a short period of flushing, but not many patients need to stop the medication because of that. So this is a really good treatment option. Now, natalizumab, and I think this is the second one we've come to now. Remember when you see MAB at the end, that's a monoclonal antibody. So these are biologic agents that have revolutionized neurology, and this was developed against that VLA4 receptor on T cells. Okay, and so by doing that, again, it makes those T cells sticky. They can't get into the central nervous system as well. And so patients come in for an infusion every 4 weeks, and just look at the difference here. So interferons and glatiramere acetate reduce relapses by 30%, natalizumab by 67 or even up to 90% in some studies. So it is very effective. So why don't we just put everyone on natalizumab? Well, here's the antibody here against the VLA4 receptors. Okay, so that's the mechanism. So the very serious potential side effect of natalizumab is PML. And PML is a condition that's very serious and frequently fatal. And so progressive multifocal leukoencephalopathy we will talk more about in our lecture on HIV. That's the other time that we think about PML. Patients with AIDS can get this as well. Dramatically affects especially posterior white matter pathways in the brain. And so when we're thinking about putting someone on natalizumab, we always first assess for a JC antibody. And if they're positive, then if at all possible, we choose a different therapy. Now, if someone is on natalizumab, you still keep checking for that JC antibody. And if they become positive, then you really need to consider changing them to a different medication. All right, fingolimod is an interesting another oral medication, and so the mechanism here appears to be to sequester T cells in the lymph nodes. So that's kind of an interesting idea here, but it is helpful. And fingolimod has 3 unique side effects. First is it can cause a really significant outbreak of the herpes virus. There have been a few fatal cases of varicella zoster in patients on this medication. And so you first need to check a varicella serology in these patients and ask if they have a history of chickenpox. And if they don't have chickenpox, didn't have chickenpox, and their serology is negative, then they need to be vaccinated before starting the medication. Also, we need to do 2 other tests. Because cardiac arrhythmias can occur, we need a baseline electrocardiogram. And we'll also send the patient to ophthalmology for some visual testing at baseline, because macular edema is another potential side effect. So just, kind of contrast here, this sounds pretty serious, right? Potentially, compared to dimethyl fumarate, where flushing was the main side effect. So that's one reason I think a lot of people are using dimethyl fumarate as an oral medication. Now, TERIFLUNOMIDE is another medication that acts through blocking pyrimidine synthesis, which reduces T and B cell proliferation. So it's an oral medication, and overall pretty well tolerated. You can't put someone who has liver problems on this, or at least that wouldn't be your choice, because it can cause an elevation of liver enzymes, and we do need to monitor liver function if we're putting a patient on this medication. Now, I am, believe it or not, limiting. I'm not telling you about all the medications that are on the market, but I'm covering the ones that are used frequently. And so the other I would like you to know about is ocrelizumab. Again, it's another monoclonal antibody, and this acts against CD20 on B cells, so it's a B cell depleter. And like natalizumab, this is highly effective. I mean, look at that, 70 to 80% reduction in relapse. And so as kind of a big news thing a couple of years ago, this appears to be beneficial for patients with primary progressive multiple sclerosis. Prior to that, we really did not have much of an option for these patients. It is contraindicated in patients that have active hepatitis B, so we do need to check for that prior to initiating this therapy. So like natalizumab, this is an infusion. Patients come in for an infusion, and then a couple weeks later, and then 6 months after that. So there's kind of a schedule for when they come in and receive their infusions. So here is a helpful, a local MS specialist shared this with me, and I thought it was quite helpful. In terms of efficacy, the interferons, GLATIRAMER acetate, and TERIFLUNOMIDE are lower overall in efficacy. Okay, in terms of median efficacy, dimethyl fumarate and FINGOLIMOD are solid, better, more effective. Okay, highly effective are natalizumab and ocrelizumab. I've not mentioned the one there in the middle because that's a very new one that's out on the market, but these monoclonal antibodies are really very effective. So here are some common sense guidelines. The safest, least side effects appears to be GLATIRAMER acetate, but even though that does have the fewest side effects, if I'm starting someone out on one of these medications and I really want to prevent as many relapses as possible, I'm going to go with something a little more effective usually. So like dimethyl fumarate, very few side effects, remember flushing, and it just has a good solid treatment to prevent relapses. If someone has a more severe form of multiple sclerosis, then really we probably should just go right to natalizumab, or certainly if maybe we started them on dimethyl fumarate, they're not having a good response, and then we'll move to natalizumab. Okay, so we often do need to, in one patient, rotate through multiple of these different medications until we find one that works the best. And then remember, for primary progressive MS, ocrelizumab is a new indication for that. Now, neuromyelitis optica, otherwise known as Devick's disease, does overlap quite a bit with multiple sclerosis in terms of symptoms and presentation, but it's an entirely different condition, different pathophysiology. And so the optic nerves and cervical spinal cord are what is primarily affected in patients with this condition. So, and this is often very severe. 50% of patients lose functional vision in at least one eye. So if we have a really bad optic neuritis, patient doesn't recover, then we're maybe a little more primed to think about this condition. Interestingly, the brain is not very involved in neuromyelitis optica. We do an MRI of the brain, not too much activity. Okay, so it's mainly optic nerve and spinal cord. And the attacks on the spinal cord are much more severe usually than in multiple sclerosis. And these can be severe to the point that involves pathways involved in breathing. So in a more dramatic attack, a patient may even have respiratory failure. Okay, that you wouldn't see that in multiple sclerosis, at least not very often. So when we do an MRI of the cervical spine, we see these very long, we call them longitudinally extensive lesions that extend across many levels. Some distinguishing, so that's a distinguishing feature. Another is if you do a lumbar puncture, they don't have oligoclonal bands like you see in multiple sclerosis. Okay, this has even a higher percentage of patients that are female, so wouldn't see neuromyelitis optica very often in men. And all of the medications I just went through for multiple sclerosis are really not effective for neuromyelitis optica. So treatment, there are a number of immunosuppressive medications, and rituximab here, which again works on these CD20 antigens on B cells. So it's another B cell depleter, but this monoclonal antibody, we have good evidence that it's effective for patients with neuromyelitis optica. All right, so diagnosis, we want to think of this again in an optic nerve, spinal cord presentation. And so we can measure these aquaporin 4 antibodies, otherwise known as neuromyelitis optica antibodies. And so this is quite helpful, sensitive, specific test for this condition. But it's important to make the correct diagnosis here because we're going to treat this very differently than multiple sclerosis. So here is an MRI scan of the brain in someone with neuromyelitis optica. We've got a couple teeny tiny little spots, not very impressive, but look at the cervical spine here. So this large area here is really a necrotic area here that involves much of the cervical spinal cord. So that's what I mean by longitudinally extensive lesions. Compare that with the MRI I showed you in the patient with multiple sclerosis, where they're just little spots here and there. Okay, so very different there.